All right, hi, I'm Dr. Jared Gardner, and I'm here today with the awesome pathology residents from the University of North Carolina, who so very kindly selected me to speak and give them a grand rounds earlier today. And now we're going to do some interesting unknown slides of a spindly or soft tissue nature. So this is an interactive session. I want you guys to answer, ask questions. Don't be afraid to be wrong. You know, remember, if you're wrong here, no one dies. This is a great place to learn from mistakes in the setting of a virtual teaching environment. Okay, and I promise I won't shame you or anything. Okay, so hopefully some of you had a chance to look at a few of these slides. Case 1, 80-year-old man with a slowly growing firm white scar-like plaque on the scalp. There is kind of a vaguely neural kind of look to this this proliferation. It's a little bit of gently wavy. There are cells, and this scan, I guess it might be a 4DX scan, I can't remember. But if you look around, there are some scattered hyperchromatic pleomorphic cells. But I mean, it doesn't stand out as, you know, obviously malignant at first glance, unless you know what it is. Once you recognize the pattern, when I put this slide down at 2x, this looks like cancer to me. But it's a very, very tricky tumor, and that's why I'm showing it to you today. So this is desmoplastic melanoma. All right, desmoplastic melanoma is very treacherous because it doesn't look particularly like any other form of melanoma. And in fact, it doesn't always look obviously malignant. It can look like scar, it can look like neurofibroma or other bland spindle cell tumors. The key to me, one thing you can do to cheat a little bit, it's not really cheating, sorry if the board ever watches this, I hope they know, but on a test you can use context clues to recognize that probably, look at this thing, someone took a huge piece out of this gentleman's scalp, all the way down to this structure here. What's this pink band along the bottom under the subcutis? Well, this is fascia, right? And in the scalp, it's basically Galea aponeurotica, or periosteum, which all kind of come very close together there right over the surface of the scalp. So they've gone all the way down almost to bone, which is common when you're excising a large cancer on the scalp. This is the way it comes out. But the point is someone probably biopsied this in the past and called it cancer to get an excision of this size on someone's scalp. So if you see a big, huge slab of tissue, you can be pretty sure, oh, this is probably going to be cancer, or else it was maybe misdiagnosed as cancer. That doesn't always hold true, but it's a good trick for tests. If you see something that looks like a cancer surgery specimen, then probably it's going to be malignant. So it's a little bit of a context clue you can use. Here's what helps me, though. There's a process here arising from the dermis. It's fibroblastic looking, kind of fibrotic. It's got pink collagen, but it doesn't stop at the dermis. Instead, it blows away the subcutis. Look, all this used to be subcutis here, and it pushes all the way through it, all the way down to fascia, and then it starts spreading out laterally. So if you imagine the other side here, this is kind of could have an hourglass kind of appearance, and I feel that's really characteristic. Desmoplastic melanomas often do that. They go all the way down to the fascia or the periosteum. Okay, that piece is not as good as this one. Over here, though, the other thing is when I see a spindle cell, kind of scar-like or fibroblastic or neural-looking lesion and these are usually in older sun-damaged people on the head and neck. The vast majority of desmoplastic melanomas are going to be on the head and neck of old sun-damaged people. The other place you occasionally see them is on acral sites underneath an acromelanoma. They can occur on the trunk or the extremities elsewhere, but very, very uncommon. They usually are on the head and neck of older people that are sun damaged. So these clusters of lymphocytes here, these are, Dr. Rapini, one of my favorite dermpath mentors, said, you know, lymphocytes are like smart bombs. They can see the antigens that we can't see. They know these cells are bad. Now, obviously, lymphocytes come to other things that are benign too, but when I see something that looks kind of scar-like or neural, and I see clusters of lymphocytes, lymphocyte aggregates, right away I start thinking desmoplastic melanoma. Okay, and the key feature then, what you're going to look for then is look at the cells, and what you'll find are spindled cells that look kind of either Schwann cell-like or fibroblast-like with scattered hyperchromatic pleomorphism. See, these aren't super ugly, but they're kind of a bit darker and uglier than a usual fibroblast or, say, a Schwann cell would be. And you sometimes have to look around for a while to find like big, like obviously atypical cells. Also, if you're lucky, you'll get mitoses. Here's a mite right here. It's a little harder to see sometimes on virtual slides, the mitoses, but there, look at that hyperchromasia there. So when I see this, it looks like a scar or neurofibroma, scattered atypia. And in between each of the cells, there's a lot of collagen and also some blue kind of myxoid material. So it gives it this kind of slightly pale pinkish blue look because of all of the background collagen in between each of the tumor cells. That's real important. For true desmoplastic melanoma, the individual tumor cells should be divided from each other. Most of them should be divided from each other by background collagen and or myxoid stroma, okay? And again, there's pleomorphism. Occasionally, they'll kind of clump together like they're trying to make little tiny spindly nests. And then the other thing you can look for is this, perineural invasion, because desmoplastic melanomas love to invade nerves. And sometimes they do it so dramatically, you can call it a neurotropic form of desmoplastic melanoma, where they can completely overrun and kind of fill up whole nerves. And so this is the reason I show this case is I've never made like a full-length desmoplastic melanoma video, so this is going to be it. I wanted to start with this one because it's a really important topic. It's a rare subtype of melanoma. Only like maybe a couple % of melanomas are desmoplastic, and it's really treacherous because it's so easy to miss and think that it's scar or that it's neurofibroma. I've had people send me a message and say, I've got this weird neurofibroma on an old person's scalp, and there's all these lymphocytes here, and I'm like, you're describing a desmoplastic melanoma. And then they sent it for consult, and sure enough, that's what it was. So I always have a low threshold, especially on a shave. If I think something looks like scar, but there's some atypia or there's some lymphocytes, it's an old sun damaged person, they don't have a good reason to have a scar there, do an S100 or a SOX10, okay? Those are the stains that are going to stain desmoplastic melanoma. A desmoplastic melanoma is going to almost always be completely negative for HMB, 45, MART1, melan-A, whichever name you like for that, and other melanocyte markers. The only stains that are really going to reliably stain with, and there's some other esoteric ones people have used, but the workhorse stains that I use is SOX10 and S100, and they're going to stain many of the spindle cells that you're going to see here. And the problem is that a neural thing would stain just the same way. So telling apart a neural tumor from a desmoplastic melanoma can occasionally be one of the most challenging differential diagnoses because you're between something totally benign and something really malignant. And so in those cases, getting help, getting a consult can be helpful. There have been occasional times I've had to tell the treating doctors on a small biopsy, I'm not sure if this is a neurofibroma or part of a desmoplastic melanoma. You need to excise it. And no one's super happy with me when I've had to do that. And I try to everything I can to avoid it. There are some other tricks some people use, like CD34 tends to have a very swirly, whirly pattern in neurofibromas. Neurofibromas are usually CD34 positive, and it tends to not have that pattern in desmoplastic melanoma. But I've found that difficult for me to totally rely on, in a really hard case. I'm still not always convinced that I can definitively decide. Once I've got a big specimen like this, it usually becomes very obvious. See the hyperchromasia there. Now, the other thing you can look for is there melanoma in situ over top? But the problem is desmoplastic melanoma is about half the time, depending on which study you look at. It seems like the ones that get sent to soft tissue pathologists usually don't have in situ. The ones that get sent to dermpats often do if you're looking at consult-based studies. So because people often think these are something neural. Because they'll be S100 positive and they'll think, oh, it's a malignant peripheral nerve sheath tumor. MPNST almost never occurs in the skin, and it's usually going to be negative or very weak positive for S100 and SOX10. I've got a whole video about MPNST, but if you think that something is an MPNST in the scalp of an old person, I assure you, I will bet you $1,000 you're going to be wrong on that. Now, someone one day is going to watch this video and come looking for that $1,000. So I'll just say not really, but I would probably put money on it because it's going to not be an MPNST. Okay. So that's desmo, and the problem is that these don't often look like melanoma clinically. They often look kind of white scar-like plaques, kind of slower growing. So clinically, they don't look that worrisome. Microscopically, they don't. So it's like a perfect storm of false clinico-pathologic correlation. And so oftentimes when these are first diagnosed, they're all the way down to fashion. Like they'll be like 14, 15 millimeters thick. Very classic. So when you have a pure desmoplastic melanoma, which means 90% of the melanoma looks like this, spindle cells with hyperchromasia divided by collagen. When 90% or more of the lesions like that, we call it pure desmoplastic. Plenty of times, though, you'll have a mixed desmoplastic melanoma that exists with regular kind of epithelioid melanoma cells or more cellular spindle cell melanoma or some other type of melanoma. Those mixed types tend to behave like regular melanomas, more or less. When you have a pure desmoplastic, they're a little unusual. They have a better overall survival on a same depth basis than other forms of melanoma. They tend to be more of a local aggressive problem than distant mets. I can't remember actually ever seeing a distant metastasis from a pure desmoplastic melanoma. I'm sure it happens, but I've seen a ton of melanomas, thousands of them, and I don't think I've ever seen one that I can recall. Also, pure desmoplastics usually do not metastasize to lymph nodes. They have a much lower chance of doing that. So it's an important thing to know. I've seen one of these grow through the skull and into the dura mater and not have metastases, and the patient was still alive. I mean, that case, I remember long ago seeing that, and it really made me realize these are totally a different sort of tumor than other types of melanoma. So Klaus Bussam from Memorial Sloan Kettering has done like some of the groundbreaking landmark work on this tumor type and has written a lot of great papers about it. I'll try to link to some of those in the video description. Highly recommend you read those if you really want to understand this disease. But I think this is a very, very classic example of pure desmoplastic, and it's one that lacked a melanoma in situ component, which makes it much more challenging. And here's the other piece, which is a little bit more cellular, but even here, the individual cells are divided by background stroma, right? By background collagen. And again, look at the sprinkling of lymphocytes here. And see, these are getting more hyperchromatic, more atypical. So if in doubt, S100 or SOX10 are your best friends. Oh, and look at that waviness. Look, it looks a little wavy, like kind of like neural sort of wavy. I don't really love the word wavy for neural because I don't think neural things are truly really wavy, but this kind of gently undulating. Oh yeah, that could look neural. It's very, very treacherous diagnosis. And hopefully this video will help other people to recognize it. Desmoplastic melanoma, this one being a pure type. Okay, let's move on to case number 2. Who would like to take this one? It is a, okay, it's a 65-year-old man with rapidly growing ulcerated black nodule on the back.
So at low power, I'm looking at a very cellular looking lesion that seems to be well circumscribed for the most part. And then I can appreciate that ulceration that they were able to see grossly just kind of from the low power as well.
Yes.
There's also a central area of very eosinophilic material, which on higher power I thought could be some cellular debris or maybe some necrosis.
Yeah, I agree. They're like ghost outlines of dead cells here, right?
And then also on higher power too, the cells kind of look very spindly.
Yeah.
And I'm seeing a lot of pigmentation as well.
Yes.
Which I'm appreciating on low power and on higher power. Perhaps like metastatic melanoma.
Okay.
Maybe.
Good. Any other people want to add to the differential? Nice.
Angiosarcoma for this one as well.
Yeah, spindle cell angiosarcoma occasionally can be really cellular and lack vascular channels. Usually, if you have a big specimen, a spindloid angiosarc, not always, but oftentimes, or same for epithelioid angiosarc, at the edges, you'll often see infiltrating channels. And so if you get a small sample, it can be really difficult. And that's why actually I usually include ERG or CD31 in when I'm looking at a malignant looking spindle cell tumor of the skin. I include like an AFX, atypical fibrosarcoma versus spindle squame versus other. I usually include a vascular marker because I've occasionally seen cases that didn't have any obvious vascular channels on a small shave, and I would have totally missed it. So I do that, and it's usually not that, but angiosarc is such a bad disease and needs a kind of a specialized management, so I definitely want to make sure I don't miss it. Well, yes. Okay, and anyone else?
I thought like what you said about like the AFX, that maybe it had like the clinical history with like a rapidly growing thing, and it was kind of nodular, and like maybe I got a little bit of a collarette.
Yeah.
Too.
Okay.
But the area of necrosis in the center made me like less convinced of that, like it's a more high grade thing.
Good. So, and when you're thinking of atypical fibrosarcoma, or the more aggressive kind of upgraded form of that is called pleomorphic dermal sarcoma, which is what we call AFX when it involves the subcutis, or when it's bigger than like I think 2 centimeters, or when there's necrosis, vascular invasion, perineural invasion. All those things kind of make us say, okay, this is probably not an indolent. AFX is probably a more aggressive pleomorphic dermal sarcoma. But what are the other main things in that malignant pleomorphic spindle cell tumor differential usually in the sun damaged skin of an older person? There's AFX, pleomorphic dermal sarcoma. I kind of lump those together because they look and stain the same, and I think they are honestly the same thing, just we give a different name based on if it has higher risk features. And what else can look like that?
Spindle cell melanoma.
Spindle cell melanoma, very good. And don't forget spindle cell squamous cell carcinoma, which is actually quite common, right? Squames can become sarcomatoid or are so poorly differentiated that they become spindled. And so I do a panel of stains, and I have a video about AFX that you can watch to see. But basically, my general panel is either a pan-keratin or a high molecular weight, like CK5-6. I used to do pan. I started using 5-6 more. A nuclear marker like P63 or P40, which sometimes spindled squames lose keratin but retain that. Although not everyone likes that because sometimes you get non-specific staining, but I still find it useful sometimes. An S100 or a SOX10, in my hands they work equivalently for spindled melanoma. And the more spindled the melanoma gets, the more it tends to lose expression of its other melanocytic markers, the more specific ones like MART, also known as melan-A, or HMB45. Not necessarily, but it can lose them. So I definitely have seen lots of spindled melanomas that are just S100 and SOX10 positive and have complete loss of melan-A and HMB45. And then people will send me those and say, I think it's malignant peripheral nerve sheath tumor. And then I tell them there's no way it's that. So, and then I also, like I said, spindled angiosarc, and I said spindle squame. And some people include leiomyosarcoma in the differential, but usually leiomyosarcoma looks like leiomyosarcoma. It has pink fascicles. Now, I will point out that this tumor here does have fascicles. Look, it's got some pretty nice streamy fascicles. It's disorganized in a lot of places, but in areas it kind of really runs in fascicles and kind of pink cells. So this is a diffusely S100 and SOX10 positive and has some patchy MART1. So this is a spindle cell melanoma, okay? And with the necrosis and the atypical mitotic figures like you can see here, definitely bad news. So this is a good example of a very ulcerated spindle cell melanoma. When you look at it, it basically looks like a sarcoma, pleomorphic, ugly, high-grade spindle cells. That's the difference between spindle cell melanoma and desmoplastic melanoma. To go back to contrast, hypocellular, divided by collagen. This is desmoplastic. This is spindle cell melanoma. Again, you can sometimes have both together, and then I would say it's a melanoma that's mixed desmoplastic and spindle cell type, and I would expect it to behave like a spindle cell melanoma despite having a desmoplastic component. You got to have more than 90% of the 90% or more of the tumor has to be desmoplastic to call it a pure desmoplastic. Okay, so that is a good example. And again, sometimes they will have an in situ component. Uh-oh, my browser froze. Oh, there it is. I've got too many windows opened, I think. Sometimes you'll have in situ, but like this one doesn't. And now why that is, we don't know. And someone brought up metastatic melanoma. That's an important consideration when you have a ball of melanoma without any in situ component. You always have to think about a MET. But sometimes big nodular melanomas and also particularly spindle cell and desmoplastic ones don't have any in situ over them. Whether that's because they used to and it regressed away, or it ulcerated away, or we just aren't getting it in the particular cut, I don't really know. We don't really understand why that happens. But it is always worthwhile to think about and check if they have any history of melanoma. If you see a nodule of melanoma in the skin that doesn't have an in situ component, particularly if it's down deeper away from the epidermis, definitely rule out MET. The ones like this that are pushed right up against the epidermis and have a big ulcer, I feel like I see these lots of times. People think about metastasis, then the treating docs work them up and get scans and everything, and they almost never end up being a MET of unknown primary when they look like this. But it's still, I mean, worth bringing up and thinking about. Definitely worthwhile, because a MET would get treated differently than a primary melanoma. Okay, and this would be going down into the subcutis, so a Clark level 5. If you still use Clark level, it's not required anymore. And probably, surely more than 4 millimeters, or like probably 12, 15 millimeters, I don't know. But really bad. And it's pretty unusual, honestly, to see big zones of necrosis in cutaneous melanomas. I only see those in really big, bulky ones like this. Otherwise, necrosis is not really that common in a primary melanoma unless it's really large. So bad news, very aggressive, bad melanoma. And this one had a melanin pigment in it, but sometimes they're totally amelanotic and lack pigment here. There's good pigment right here. Oh. Good melanin pigment there. Okay. So that can be really helpful. All right, and let me show you just a brief example of the immunostain. Here's another example, a shave biopsy Ooh, this one's a treacherous lesion. Look at that. I mean, there are scattered hyperchromatic cells, but otherwise you might really struggle to wonder what this is. But look at low power. Lymphocyte aggregates, the smart bombs are there. And we've got this kind of myxoid and fibrotic background and hyperchromatic spindle cells scattered in the middle of it. And in this one, we're lucky because we got melanoma in situ component over the top. Kind of nested, almost a little bit nevoid looking, but the whole thing is melanoma in this case. So let me show you. This is a desmoplastic melanoma that is pure, but also had an in situ component. You don't count the in situ for pure versus mixed. And then here's an example of what it looked like on S100 stain. S100 stains the in situ component. And also you can see all the dermis is filled with desmoplastic melanoma going all the way to the base. Like I said, these are often 10 millimeters or more at the time of diagnosis. They often really don't show up clinically until they're pretty late. And then to contrast, here's an example of MART1, which you can see is positive in the in situ component and in a few scattered cells, maybe right underneath in the papillary dermis, and then completely lost, gone. Okay, that is the typical pattern that you would see in a pure desmoplastic melanoma. They're almost always completely negative for MART1 and HMB45 unless they've got an in situ area up top. Okay, case 3. This was what was the history? It was a 70-year-old woman with a skin-colored nodule in the back. Clinically, they wanted sebaceous cyst. You know what I say? If you've watched any of my stuff online, you know it's like one of my pet peeves. It's always a cyst or a lipoma until it's not. So, I can't tell you how many rare cancer patients with dermatofibrosarcoma protuberans and other diseases that were clinically misdiagnosed as cyst. Because any nodule that's down in the deep dermis or subcutaneous is going to look like a skin-colored bump. And cysts and lipomas are common. So it's understandable, but this is why it's important to consider biopsying lesions. Okay, so who takes this one?
I'll take this one. So this looks like a well-circumscribed, relatively well-circumscribed lesion within the deep dermis. In terms of architecture, if you can go the type where the cells tend to have some sort of testicular pattern, they're running in these bundles. The cells have bland, the cells are bland, they have round nuclei, and some vesicular chromatin with some hypernucleoli. There is an important lymphocytic infiltrate.
Here, I'm trying to move, sorry.
Yeah, there seems to be a lot of vascular spaces.
Yep, true. It can sometimes be hard to tell, and especially on a scan. But yeah, I feel like right here, see, there's an endothelial cell, and it's making a lumen. And then around here, there's a pericyte, which is that little muscle cell that wraps. And then the tumor cells are out. So even though the nuclei do look pretty similar, I feel like these are probably discrete little vessels in the background. But admittedly, that can actually be really challenging, especially tumors that are hypervascular. I find that a lot of times pathologists have a tendency to want to think that the tumor is making vessels when it's actually just a background vascular network. And I have to admit, though, that learning the vascular patterns and features of soft tissue tumors was really one of the later things that I learned. And I still was struggling to acquire it towards the end of my fellowship and into practice. So it's something a lot of times people talk about, oh, there's these dilated vessels or this kind of vessel or that. For my mind, I found it actually kind of hard sometimes early on, especially in my training, even in fellowship, to pick up on the different vascular patterns and what their significance was. And that was something that didn't really come until I was well into practice, really, and had seen a lot of tumors. So there's an area I wanted to show you here.
I remember there was also one area with a lot of multinuclei.
Yeah, there we go. Giant cells.
Giant cells, yeah.
They almost look kind of like Teuton giant cells, don't they? They've got like a little ring of nuclei, looks like a little bubbly at the edge and kind of smooth and pink in the middle. Because this is a really interesting case, I put in a few extra slides, but I think really this slide is the the best one. So I won't show the others, but anyone watching this online, I'll put links to the digital slides and you can really see all of them. This is a really difficult case. So if you couldn't figure it out, don't feel bad, because I actually struggled to figure this one out myself. Because I've only seen actually 2 of this entity in my life, in my whole career, including fellowship. And I saw both of these tumors. They were sent to me as consults from the same pathologist, both from different patients, and they were sent to me like a month apart. I kind of felt like I was going crazy because I thought they're going to not believe me that I'm making a really rare diagnosis on 2 of their patients like a month apart, and then I've never seen another one since. But I'm always on the lookout, and I think this one came in second, and I recognized it right away, or very quickly. But the first one, I actually did a fair number of immunostains trying to figure out what it was until the idea occurred to me, and I did the right stain. Xanthogranuloma is a good idea, right? It looks like Teuton giant cells, and we've got lymphocytes and kind of fibrohistiocytic looking background. I mean, it's really hard to look at these cells. I mean, there's a ton of lymphocytes here, but otherwise, like, what are these spindled cells? Are they fibroblasts? Are they histiocytes? They kind of, that's why fibrohistiocytic you can kind of think of, because they kind of are something in that zone between fibroblast and histiocyte. They don't really fit perfectly into any one cell type, right? Let me show you a stain that I did. See what you think. I'm not going to tell you the stain. I'll let you tell me what the stain is. Does anyone recognize this stain? It's still coming into focus. And if not, I'll show you a closer high-power picture of to really clarify it.
Looks like a bug stain.
Ah, which one?
AFB.
Yes. That's the close-up picture there. Look at those giant cells. They're fake Teuton giant cells. So in fact, I'll give a shout out to 2 of my online friends, Sanjay Mukhopadhyay and Marcella Saiblima, who are both great, amazing people to follow on Twitter. They, through a conversation, came up with the idea that sometimes cryptococcus makes these kind of pseudo-Teuton giant cells, that it's crypto-organism around the outside instead of foam, like a real Teuton cell. So we kind of jokingly call those Crouton cells because it's like crypto and Teuton. It's like a portmanteau of those 2 words, which is, I thought, super fun. And I actually put that in my DermPath survival guidebook, and I cited the tweet thread, and that's how it's done. So now it's embedded into the real literature, I suppose. Maybe not PubMed, but it's in a book. So in any case, I feel like this is the exact same phenomenon, only instead of crypto, it's happening with these acid-fast bacilli. And you know what's really cool? These are so numerous that they were actually even positive on PAS stain. So I've seen this a couple times when there were tons and tons of mycobacteria, they'll actually stain with PAS. No problem to tell these are not fungi. They're a little tiny thread-like thing, right? Fungus. I think I took these pictures on like 60x high dry objective. So really hard to get good pictures. So on a scan, it still doesn't show up really well. But don't be confused by that sometimes PAS can stain AFB and also other bacteria occasionally as well. But definitely these don't look morphologically like fungi. So this is like the most dramatic example. And here, this is the scan. Look at how much. So not every cell, but especially these foamy cells, just loaded and loaded, not with foam, not with lipid, but actually with mycobacteria. So then what would you call this thing? I mean, why it's making a mass. It looks like a tumor, right? So this is a mycobacterial spindle cell pseudotumor. Sometimes mycobacterial infections produce a really exuberant fibroblastic and histiocytic and inflammatory response that makes a kind of inflammatory pseudotumor. The one other thing you could think of looking at this is inflammatory myofibroblastic tumor, which in the olden days was often called inflammatory pseudotumor, but now we recognize that there's kind of a group of things that can look inflammatory and pseudotumoral, and not all of those are true IMTs, which often express ALK1. So if you were thinking about that, you could try ALK1 here. But yeah, sometimes mycobacteria make pseudotumoral response, and this is just a dramatic example. They often are in immunosuppressed patients, and they're often multifocal. To my recollection, this patient didn't have any known immunosuppression. It was just one nodule, but I never did get follow-up, and I don't believe I ever found out what organism this was, what this ended up being. But I would say that this is probably an atypical, non-tuberculosis, non-leprosy form of mycobacteria, just mainly because when I see older people with mycobacteria in the skin, sometimes it's leprosy. Like in the South where I used to live in Arkansas, we would occasionally see leprosy in the skin. But otherwise, when I saw acid-fast bacilli in the skin of older people, they usually ended up being atypical AFB. So, I mean, you still don't know without culturing or molecular to be sure. But this is a really dramatic example. The other case I saw of this did not have these beautiful cells loaded with organism, but had this background of lymphocytes and fibrohistiocytic stuff and a little bit of granulomas. And that was one I really struggled. I must have done like 10 immunostains thinking it was going to be some spindle cell tumor. And then I saw the granulomas and I saw some plasma cells and I thought, maybe I should do bug stains, and it was phyte positive, and I couldn't believe it. So the other thing, leprosy can do this too. And when leprosy makes a pseudotumor, it's called histoid leprosy. It's a form of lepromatous multivascular leprosy. And I've got a really beautiful example of a digital slide of that on Kiko, the only example I think that I've seen in my practice. So if you want to see that, I'll add a video link down below. Let me add that to my, my to-do list for editing here. Okay, histoid leprosy, I'll put a link. Okay, guys, so that is a really challenging case. I did not expect anyone to figure it out, but you've seen something now that's incredibly ultra rare, and that's the AFB, and this was the PAS. Just loads of organisms. Unreal, huh? Unbelievable. I think sometimes older people get these because as people get old, they tend to get some natural immunoparesis or diminishment of their immune system. And I've seen this with Mycobacterial a lot, where people have loads of organisms when they're old and they don't have any other form of immunosuppression. I feel like it's probably worthwhile to work those patients up for like chronic lymphocytic leukemia, because that's a common finding in older people, and it can give people immunosuppression. I've seen people with really aggressive, squamous cell carcinomas and other things that showed up, and then it turns out the patient had CLL that wasn't diagnosed yet. So I think it's not a bad idea to work them up for underlying immunosuppression when you see something like this. Okay, close these out.
I had a question. So on the last slide of the third case, I think that's slide number 4, number 5.
Yeah, that one.
Yeah. So are these the presence of these vascular spaces is part of this pseudotumor? I don't know if these are actually vascular spaces.
I don't know. I think probably what this is a little circular areas of fat necrosis. See, if you look around the edge, I think that is a giant cell that's squished. And sometimes you can get little cystic pockets in fat necrosis, like for example in post-traumatic fat necrosis or in lipodermatosclerosis, which I was going to show at Grand Rounds, but I ran out of time because I talked too much. But sometimes that can happen. You can get little circular spaces of fat necrosis. And I think around the edge here, those are histiocytes and giant cells. See like that? Look at that multinucleation. It's squished. So it's hard and it kind of looks like an endothelial cell, but endothelial cells shouldn't be multinucleated like that. So if I were going to, you could do stain an endothelial marker like an ERG and a CD68. Do be careful. CD31 stains histiocytes oftentimes. It's usually weak granular staining. I've got a little video that shows some examples of that, but that can occasionally, I've seen people occasionally send things in thinking they're angiosarcoma when they're actually a histiocytic infiltrate. Because there is kind of a foamy, bubbly version of angiosarc. It's terrifying, very treacherous. But in any case, 31 is sometimes will stain, but it won't stain as strong as the vessels. So again, if you want to see, go watch that video, and I show back to back so you can see. No vascular stain's perfect. CD34 is lost in some angiosarcomas, tends to be weaker, or I'm sorry, lost completely in some angiosarcs, and it also stains lots of other stuff in the fibroblastic and neural things, okay? CD31 is a really sensitive marker and pretty specific, but it also stains histiocytes. So in tumors where there's a lot of histiocytes in the background, that can be a problem. And then ERG is a really, in my hands, very, very sensitive. I have never, knocking on wood here, seen an ERG negative vascular lesion of any sort. I'm sure I will eventually, but if ERG is negative or only patchy or focal positive and it's kind of weak, that is a strong, strong, strong argument against a vascular tumor of any kind in my experience. Now, that said, though, ERG is not specific. It stains lots of other stuff. It stains prostate cancer. It stains about half of epithelioid sarcomas, and it can stain a variety of other things too. So, none of them are perfect markers, but in hard cases, I can use them in combination. But yeah, I think these are little bubbles, pockets of fat necrosis. Look at that. See a giant cell there? I think that's what that is. Good question, though. And I think this is just cystic breakdown in the middle. I'm not sure if it actually is true in vivo, like what it was in the patient, or if it's a zone of fat necrosis, or if it kind of fell apart during processing in the lab. I can't really tell. There's no like real blood in here. So it may just be that this central part kind of fell apart during processing in the laboratory. That's quite possible. Great question, though. And I like it. You brought up about the idea of angiomatoid FH. I definitely think from low power, that's a great idea. I mean, there's not a, usually those have a pretty dense cuff of lymphocytes and plasma cells, but not always. There are, Steve Billings has written a really great paper about unusual variants of angiomatoid FH. I think with Summer Bowman, my former co-fellow at Emory when I was there. She was Surg Path when I was soft tissue, and then she went and did soft tissue at Cleveland Clinic. In any case, really great examples of angiomatoid FH that didn't have good blood-filled spaces, that didn't have good lymphoid cuff. I've seen some that have real whirling, swirling, almost perineurioma-like areas, weird ones that would make you not think of it. So it's good to read that and recognize there's definitely a spectrum of changes. So yeah, if in doubt, that's a great tumor. When you think you got a fibrohistiocytic looking thing and you see some spaces or some lymphs and plasma cells, always think, oh, could it be angiomatoid FH? Because they're rare and they're easy to miss, and they can sometimes have a kind of intermediate malignant behavior, can metastasize to nodes and stuff. So,
Thank you very much.
You're welcome. More of those giant cells. Oh, I can't get enough of that. So good. All right, guys. Now, case 4, and I have to tell you, I gave you a particularly hard and unusual set today because I'm trying to do use cases of things I've not made videos of yet, and the pickings are getting kind of slim. So a lot of the easier entities have been taken. So I'm really sorry. I'm showing you really cool stuff that's also really rare and difficult. So you guys are being real troopers, but hopefully you'll enjoy this. This is a 40-year-old man with a slow-growing subcutaneous nodule on the forearm. And here we've got 2 slides. Here's 1 and 2, and I'm going to go and use this one to zoom in on at higher power. Okay, what did you think about this?
So it looks like we have a tumor down in the subcutis or subcutaneous tissues. It kind of looks vaguely nodular or lobular from low power.
Good.
With some pushing borders. Doesn't really look very well circumscribed to me. Again, from low power, we can see there's kind of different zones of the tumor, like maybe a more myxoid area, some inflammatory areas, and also some like more pink, maybe fibrous areas. And then
what is this? Just out of curiosity, what's this structure right here? Do you recognize this?
Is this like another fascia?
It's fascia. Good. So it's really nice to get used to seeing fascia because it tells you right away. Sometimes when you don't have a full, like here we got full thickness, right? We got skin, epidermis, dermis, subcutis, fascia, and then underlying skeletal muscle. But you don't always get that. Sometimes you get a chunk of tumor taken out. And if you recognize fascia, dense regular bundles of connective tissue, and I've got a whole video on that called the ramen noodle sign, because my fellow Ed Fulton said that when you see dense regular collagen, it gets real wavy. So if it's ultra wavy, it's probably actually collagen, fibroblastic, not neural. So he said it's like ramen noodles in a package. This one's not perfect, but I love that. And I was like, oh, it's the ramen noodle sign of Ed Fulton. So in honor of my awesome former fellow Ed, I called it that. And yeah, recognizing this though, which is going to be fascia, tendon, ligament, rectus sheath of the muscle, all of those things, it can tell you where you are, even if you don't have anything else for context. You can say, look, we're down at the fascia level. So it can be really useful in real life practice actually to recognize fascia. And I find that a lot of even practicing pathologists sometimes struggle to recognize dense, regular connective tissue because it can kind of get confused with muscle or nerve or other things. All right, sorry, I didn't mean to sidetrack too much, but yeah, what do you think now going in closer?
Yeah, so on higher power, again, we have these like nice myxoid areas. And the tumor cells seem very pleomorphic.
Yeah.
There's a lot of hyperchromasia. Some of them have really crazy, prominent, giant nucleoli.
Yeah, it's like as big as its neighbor. It's amazing.
Yeah, and there's a really dense inflammatory component with a lot of eosinophils.
I like all the things you're saying.
There's also a lot of cells that have like almost like viral inclusion.
You know what it is. Good.
So I was thinking this is like a myxoinflammatory fibroblastic sarcoma.
Excellent.
Or a myxofibrosarcoma.
That is the main differential. Exactly. This is when I'm in the subcutis and I see a lot of myxoid stuff and big ugly cells. The main things I'm going to think of right away, I'm going to think of myxofibrosarcoma. But once I start seeing a ton of inflammation and or big, huge nucleoli, then the next thing I'm going to think of is myxoinflammatory fibroblastic sarcoma. And this is why people hate soft tissue pathology, because we name things in very confusing and difficult ways. But this tumor used to have an even longer name, although it was pretty descriptive. It was described by a couple groups in the late 90s around the same time. And Dr. Weiss, my mentor, her group, they called it inflammatory myxohyalin tumor of the distal extremities with Reed-Sternberg and virussite-like cells. Now, that name had to get changed because it's too long to fit into a tweet. I'm just joking. It actually does nowadays, but it takes up most of the words in a tweet. But I actually kind of like that name, even though we recognize now these are a form of sarcoma. I like that because that name tells you all the features you're going to see. There are cells that look like Reed-Sternberg cells, like right here. Look at that. It's like two little owl eyes with big nucleoli, right? And then you see these big prominent nucleoli that sometimes are so giant they look like a CMV viral inclusion. I found one. Let me see if I can find it again. That's a pretty huge one right there. They're big, very discrete, like CMV looking nucleoli. Like they really jump out at you. And then there's tons of inflammation, and it can be neutrophils, EOs, lymphs, plasma cells, a mixture of those. So when I see a lot of that, that's what I think. Now, if it's an old person and it's oh, there we go. There it was. Look at that guy. That's enormous. It's bigger than most of the other tumor cells. That's just so huge. It's awesome. So if you have a ton of myxoid change and the tumor's large, then I start thinking, well, this may be just myxofibrosarcoma, especially if it's an older person. These tend to arise on the hands or less likely the feet, but more recent studies have shown that that's the classic finding, is they're on the fingers or hand or on the feet. But now we know that they sometimes arise like on the more proximal extremities, or maybe even rarely the trunk. So, and they tend to be kind of a few centimeters, kind of smaller in size. They often are real ugly without many mitoses, but sometimes they do have mites, even atypical ones. This one had scattered atypical mites. Look at that huge nucleolus there. It's just, you can't look away. It's too amazing. If you don't like this, I don't know how to help you. It's just too good. All right. These are and there have been occasional times where I couldn't tell for sure, and I said it's a pleomorphic sarcoma, and the differential is myxofibrosarc and myxoinflammatory fibroblastic sarcoma. The treatment is going to be managed more or less the same way, although there may be debate about whether or not to use radiation, but they're going to try to excise it with negative margins. The difference is in prognosis. The higher grade forms of myxofibrosarc can metastasize. This tumor, it's very rare to get metastases, but it tends to recur again and again and be locally aggressive because it's kind of infiltrative, just like myxofibrosarcoma, same issue there. Infiltrates at the edge along the fascia, and it grows back again and again. And I have a whole long video about that topic that you can check out if you want. And when these are on the finger or the hand, obviously it's going to be a problem, and a fair number of times these patients end up with a partial, either a digit amputation or maybe worse, depending on the location, because of the tendency for repeated local recurrence. Okay, but when they're in other sites, they may be able to get wider margins around them and have less of a chance of recurrence. So there have been debate over the years about what this tumor is and what molecular. Some people think it's related to this rare entity called hemosiderotic fibrolipomatous tumor, but there's still kind of a debate and controversy. So you don't really need to, I think, delve into that. But hopefully, if you're watching this years in the future, hopefully it'll all be solved by then. Some cases have been reported to have a TGF-BR3 or MGEA5. Hard to remember those. Gene rearrangements, but not all. And again, that goes back to, is it related to hemosiderotic fibrolipomatous tumor or not? But more recently, they found that about a third of cases have BRAF mutations. So I've never used that. I think the last time I saw one of these that I had trouble with, it was before that was described. But in a difficult case, you could try doing BRAF gene mutation to see if that's helpful to further confirm the diagnosis. So myxoinflammatory fibroblastic sarcoma, or MIFS for an abbreviation. And I think this is a very, very characteristic classic example of this lesion. Okay, any questions? All right, then let's go on to case 5. I think we might get done here. It's possible we'll go over a few minutes. This one is a 10-year-old boy with a nodule on the palmar surface of the hand. Who would like to take this?
I can take this one. So this is a pretty well circumscribed nodule.
Yep.
It has a very heterogeneous appearance to it. And it looks like there's some calcification there, like that's what those darker areas are. They're not really like well delineated though. They're kind of amorphous looking. And it does look like there's a little bit of like sort of palisading around them from these really like plump looking cells.
Yep.
There are some giant cells or like some multinucleated cells in there as well, and it looked to me like there was some areas of like more chondroid-looking differentiation.
Yes.
So I think all that coupled with the history of a young person with like a nodule on the palm of their hand, I was thinking this was a calcifying aponeurotic fibroma.
Yes, very good. You nailed it. This is about as good as you can ask for example. And this slide is a courtesy of one of my awesome soft tissue mentors, Dr. Mark Edgar, who, along with Sharon Weiss, trained me during my fellowship at Emory. And Mark let me borrow this and some other slides for scanning. So thank you very much, Mark. I really appreciate it because this is really just a perfect example. So yeah, these are really quite rare. I've only seen a handful of them in my training and practice. They tend to occur in young people, often like in the 5 to 15-year-old range, although occasionally you can see them in young adults. I think I saw one once at a 30-year-old, if I recall. And the classic finding is just like you described. You have not islands of various amounts of calcification, and those islands usually have kind of a chondroid appearance. So they look kind of cartilage or myxohyaline, chondromyxoid kind of appearance with variable amount of calcification. And then around the outside, those little round chondroid cells really line up. And I like how you said it, they palisade. Sometimes they almost form these little like rows, like spokes on a bicycle wheel, kind of pushing outwards. And then as you get further away from the edge of the nodule, look what happens. It transitions. And like you said, it's kind of a biphasic, like it's got different patterns. You got these chondroid islands with calcification, and then in between, look what happens. You get these spindle cell areas. So this kind of swirls away into what looks more like fascicles of fibroblastic cells, almost like the fascicles of, like, say, fibromatosis, only much thinner and not nearly as broad as like you would see in a true fibromatosis. So that is the features that you're going to get: the calcium, the myxoid to chondroid areas, the round cells palisading around, and then these nice fascicles in between. Sometimes there can be abundant calcification or abundant cartilage. That can happen more often when you see them in older patients or longer standing, that they tend to get more calcified and more cartilage metaplasia in them over time. And in those cases, it can be challenging. I did see one that was not recognized at first until it recurred, because it then had some classic areas, but because it had a lot of cartilage, I think it was thought to be like synovial chondromatosis or something, but then it came back 10 years later and we actually had some classic areas. And so when there's a lot of cartilage and not classic features, it can occasionally be challenging to recognize. And just like anytime there's calcification or even bone formation, osteoclastic giant cells can show up, just like we see here. And that goes with, really, whenever there's bone and calcs around, it's not unusual to see osteoclasts there. They home in for that, So this is a really, really good example. And again, if you're watching this at home, I'm going to put a link to the digital slides so you can really take your time exploring all of the features. This is what to burn into your brain as just a true example of calcifying aponeurotic fibroma. They can recur locally, have a tendency to recur locally, even though they're not malignant. And I think that's true of a lot of things on the hands and feet in the soft tissue world, that they have a bit more of a tendency to come back because they tend to be closely attached to the tendons and tendon sheaths. But yeah, this one can be a recurrence and be problematic in that way. But to my knowledge, they're not usually like aggressive recurrences. They just, like I saw that one that grew back 10 years later. So, the patient had to come back in and get it removed, but he didn't have any real problem. And more recently, a gene fusion has been described in these. It's FN1 fused with EGF. Now, I've never used that in practice because, like I said, I've only seen a few, and the ones I've seen had diagnostic features. But in my reading, like in the new WHO book, it mentions you don't normally need that. But if you had a difficult case that had a lot of chondroid or calcified areas and you couldn't see the classic findings, you could potentially consider doing a test for that fusion. So perfect example, calcifying aponeurotic fibroma. Excellent job. Good work. All right, case 6. 30-year-old woman with an intramuscular thigh mass, no connection to bone, on imaging. And I think I put 3 slides in here, but I think the first one shows us pretty much what we need to see. Anyone want to take this? Okay.
All right, so on this, you can actually see kind of like a bimorphic pattern. This one, you have like this area of cells that have like these small, more round cells that have like these thin-walled branching vascular pattern that's kind of paired with these other areas of calcification, ossification, and then even within here you have like, you get up having islands of like wispy hyaline cartilage.
Ooh.
And so with this combination of like this bimorphic pattern and this thin wall branching, I thought this was some extra skeletal mesenchymal chondrosarcoma.
Excellent work. Yeah, this is be about as classic as you can ask for. A mesenchymal chondrosarcoma. They can occur either in the soft tissue, like this case, or in the bone. I think a little bit more common in the bone. The jaw is a good site, but other places around the skull, the meninges can sometimes can grow from the meninges. So a lot of times I think of them as head and neck tumors, but they're definitely well described in the ribs and the extremities, both in bone and soft tissue. So really can occur anywhere. And they tend to be, teens to young adults, but they can also occur in a wide age range. The classic features are just like you described. We get islands of kind of mature, well-differentiated cartilage. Although I like your point, I think it kind of has it doesn't look like to me like totally normal cartilage, but it's obviously recognizable as cartilage. But I like that point. It's kind of a wispy, the matrix becomes wispy and almost osteoid-like. And then in this case, there is actually some true metaplastic bone formation, which is why I told you that, this could be confusing, and you could think this is maybe in the bone, but that's why I mentioned that on imaging, this was not connected to bone. So this is just some metaplastic bone, which can happen in these. That's forming, I think, probably from the cartilage here in this tumor. So the key is finding those islands of cartilage, and then in the background, you've got a round blue cell tumor, right? It's made of monotonous small round blue cells, and they're monotonous because why? There's a translocation in these tumors, and most sarcomas that have gene fusions or translocations tend to have uniform monotonous cells rather than pleomorphism, with a few exceptions. But in general, if you think about it, Ewing sarcoma, synovial sarcoma, and on, they may look malignant because of mitoses or necrosis, but they don't have pleomorphism usually because all the cells have the same exact gene abnormality. And that's another pearl taught to me by my mentor, Mark Edgar. So I really love that, and I find that incredibly useful in practice. And so does anyone know what the gene fusion is described in this entity?
Yeah, it's going to be TA8HA1NCAO2.
Yeah, exactly. HA1, NCoA2. At least I try to make genes pronounceable. I don't know if that's legit with all my colleagues who are molecular pathologists, but I have to do it to remember them because otherwise it's like strings of letters and numbers and they just don't stick in my head. So I have to try to make ways to say them. So HA1, NCoA2, which in this case was positive for, but I mean, really the features are diagnostic here, I think. The bigger problem is if you get a small biopsy and you just get the round blue cell area, right? Then you got to think about Ewing's and a variety of other things. The key here is the branching staghorn hemangioparasitic vascular pattern, if you like that terminology, the branching dilated, really prominent vascular network here in between the tumor cells, and they're round blue with that network. Always think of mesenchymal chondrosarcoma, even if you don't see the cartilage areas, and then you can send it for molecular in that case. A problematic thing with these tumors is that they can have a kind of an unusual mixture of immunohistochemical findings. They can be positive for CD99, like the majority of round blue cell tumors will. Dr. Weiss said CD99 is a marker of small round blueness. If it's a small round blue cell, unless it's like a neuroblastoma, which is classically 99 negative, everything else is going to stain with CD99 oftentimes, okay? So be very wary. I really only find CD99 useful in the workup of round blue cell tumors. If it's positive, then I usually will reflex on. If I'm thinking of Ewing's, I'll go on to do Ewing's molecular. Or if it's negative, then I feel pretty comfortable that it's probably not Ewing's, okay? So that's really the main use of CD99. It's described in a lot of other entities, solitary fibrous tumor and stuff. I just don't find it helpful there because it's so nonspecific. So it's not as bad as my menton, which is no place in soft tissue pathology in the modern times, in my opinion. But in any case, so what this is positive for 99. It can also be positive for S100, and it can be positive occasionally for EMA, Desmond, myogenin, MyoD1, the markers of rhabdomyosarcoma. So you could really go down the tubes if you had some of that staining and round blue cells and you thought it was an alveolar rhabdo. Now, I've only seen a few of these, and I've never seen one to my knowledge that was Desmond and myogenin, MyoD1 staining. I don't know. I would assume it's kind of focal, and in alveolar rhabdomyosarcoma, you usually have diffuse, like all the cells stained with myogenin. So that might be a helpful feature, but that's a real big pitfall because if you see a malignant round blue cell thing and you see Desmond and myogenin or MyoD1, I mean, the first and third and fourth and fifth thing that comes to your mind, I mean, everything you think of is rhabdo. Important to keep that pitfall in mind to make sure that you know that these can occasionally mimic rhabdo on immunostains. So really characteristic example, mesenchymal chondrosarcoma. Excellent work. All right, and then wrapping up here, and with a really dramatic example here is case 7. The history is, and then I'll come back to the gross. A 60-year-old man with a large destructive lytic pelvic bone mass that extended all the way from the acetabulum all the way back to the sacroiliac joint. And this obviously is malignant, right? Because this is a hemipelvectomy specimen. So I don't have the radiograph to show you, but I will show you the gross, which here I think accomplishes really quite the same thing. So there's a really dramatic gross example, and you can see the acetabulum here, and here's tumor just filling all of the medullary cavity, some little islands breaking away from the main mass, glistening, kind of whitish, translucent, and you can see it going all the way back here. Here's the iliac wing, all the way back to the sacroiliac joint right there, and kind of eroding into the joint space a little bit, but not definitively crossing into the sacrum. And if you've never grossed a hemipelvectomy, let me tell you, that anatomy is a lot more complex than it seems like at first glance, especially if it comes without a leg. It's just like an internal hemipelvectomy. I usually have to have help from my surgery colleagues to help me orient them. I still find it really challenging to figure out all the different areas. So if there's ever a time you want your surgeon to come look at a specimen with you, it's when you have a complex ortho case like that. Okay, so that is the gross image here. And then let's look at the slide. And I did, because this is a good example of something pretty uncommon, I put in like 5 slides, and I'll show you a few of them here. All right, who would like to describe it?
I can do that.
Okay.
So in this first set of slides that we have here, essentially the entire left side is involved by this kind of chondroid stroma with a bunch of atypical looking cells filling up the marrow space. I think this is all marrow space that's being infiltrated. It looks like trabecular bone and not necessarily like tumor bone.
Very good. That's a hugely important thing to figure out. And so how did you make that distinction? I'm curious.
Well, partly architecturally, it looks like it's forming as trabecular. It looks like there's normal osteocytes contained within it.
Yeah, right. It's lamellar bone, right? It's got osteocytes and lacunae. It's got nice lamellar bone lines. So when a tumor makes new bone, it usually has like the look of woven bone, just like woven bone can be made by some tumors or as a reactive reparative process. I think when I see woven bone, it's always abnormal. It doesn't mean always tumor, but it always means it's either the body repairing an injury, which is technically some sort of pathology, even if the body's doing what it's supposed to, or it's tumor-making bone or metaplastic bone. Both benign and malignant tumors can do that. But once you have nice lamellar bone, metaplastic bone can eventually become lamellar over time. But here, like you said, it's got the perfect trabecular architecture and it's lamellar bone. This is pre-existing bone being completely surrounded and infiltrated by tumor, right? So what is this right here? What's the diagnosis?
And this would suggest a chondrosarcoma.
Absolutely. This is the hallmark of what we want for chondrosarcoma. The grade 1 low-grade chondrosarcomas, which the WHO that just came out this year for bone and soft tissue has some new terminology that I encourage you to go read. It's a little bit complicated, but on the low end of the spectrum is always a challenge of telling, is it an enchondroma versus a grade 1 chondrosarc? And I got Andrew Rosenberg, an amazing bone pathologist, to come and sit down with me at the Scope and a couple years ago and tell me about this. And I made a video of it, and I've got that on my channel. I'll put a link down below. I highly recommend it. He is an absolutely master educator, just incredible. I learned so much from him. But the infiltration, or what we call permeative growth, is the classic feature of chondrosarcomas. And in the grade 1 chondrosarcomas, the low grade 1, to me, that's the main and sometimes only feature. The problem is a lot of times all you get is a biopsy or curette fragments, which makes it almost impossible to see if there's any permeative growth. But if you're wondering, when people talk about permeative growth in a cartilage lesion, this is what it is. This is classic islands of pre-existing bone completely surrounded by chondroid matrix and tumor cells. But here we don't really even need the entrapment to tell that it's malignant. Well, for one thing, on the imaging and the gross, we know that it's growing in a malignant way. And here it's way too cellular, it's hyperchromatic, atypical nuclei. Although I think that assessing nuclear atypia in chondroid lesions is actually really challenging because they often have kind of little dark cytoplasm that clumps around the nucleus. And it makes it really hard to see, like, is that nucleus? Is it cytoplasm? I can't tell. But the cellularity here I mean, it does to me look atypical, but if you struggle with that, so do I. So just FYI, anyone watching this, if you find it hard to evaluate chondrocyte atypia, you're not alone. So in any case, a 2-cellular, it's a lot of myxoidy backgrounds here, which is another worrisome feature. So yeah, I would call this, based on this one area of the slide, I would say this is chondrosarcoma grade 2. At least I don't see any areas that I would call grade 3, but grading chondrosarcomas is very subjective and not everyone agrees on it. So there may be a bone pathologist watch this and be like, Jared's crazy, and that's fine. I'm cool with that. This is the cortex, and this is tumor, but this cartilage looks very, very different, doesn't it?
Right.
And then there's a space, and then there's more cartilage that looks like that. Then there's another bone. This is something you probably rarely ever get to see. It's certainly never a specimen like this. This one turned out with just perfect sections. It's like really the best, most demonstrative example I've ever seen. I'll show you the gross again. What you're seeing is this. That's the sacroiliac joint right there. It's that is the cartilage at the joint space. Isn't that amazing to see? And so sometimes it's hard on bone specimens, especially if you have lower grade cartilage thing, to tell, is that cartilage part of the tumor or is it part of cartilage that lines the joint, particularly like in the ribs? This can be a problem. And so when you see cartilage, it looks really different and it's got like some little clusters, chondrocyte clones. It's probably got some degenerative joint disease kind of changes here. Yeah, that's actually just his normal, or not totally normal, it's reactive. But that's his background cartilage that lines the joint. He does have some damage to the cortex here, but definitive, like this is, I don't know exactly if this is a little bit of a fracture or reactive, but I didn't see definitive tumor going all the way across, I don't think. Like this was the closest area, but I think this is all disruption of the joint cartilage here. So you can see where the bone ends here, and then there's the joint. There's I guess a ligament. I'm sure an orthopedic surgeon would know the name for that, but I don't. So as much as I like bone and soft tissue tumors, I was not a huge fan of bone and soft tissue anatomy in med school. It's true story, sorry. All right, so sorry, I went on, and now let's see the other area. A really, really amazing specimen, a very unfortunate case for the patient. So, okay, so what else? Let me go to the next slide, and then you can tell me about that. Which one was the best? Probably this one's good. This one's really kind of washed out. I think it was from the scanning, having trouble telling the real pale. Sometimes chondroid and myxoid things, the light source can have a problem, but it's actually convenient here because look, it gives us a good look at the nuclei. Even though they're washed out, they are really big and ugly. When I start seeing pleomorphic nuclei and real cellular areas, then I would say this is to me grade 3 chondrosarcoma. Really, I want to see like big pleomorphism and ideally find some mitoses to say grade 3. Okay, but then what's happening over here? Did you see this area?
Yeah, so there are some areas here that almost look dedifferentiated. Like there's these large atypical pleomorphic spindle cell looking cells that don't really have any chondroid differentiation left.
Very good.
Looks like they're forming osteoid.
Yeah.
There's like an osteosarcomatous component to this as well.
Very good. So what would your line diagnosis be for this lesion?
Yeah, so this is kind of what I was struggling with. Whether this is a dedifferentiated chondrosarcoma versus a chondroblastic osteosarcoma.
Well, it's really challenging, right? And especially on a needle biopsy, it could be impossible to tell on H&E. So I'll have to tell you the honest truth. This I remember this case because this was the first time I had seen one of these, and I was struggling. I thought this is clearly cartilaginous everywhere else in the tumor. It's clearly chondrosarcoma on the gross. You can't really even very much appreciate these areas of osteoid. And on the imaging, it was clearly on imaging on MRI and some other things, the musculoskeletal radiologist usually can tell apart chondrosarc and osteosarc. So when you're struggling, that's the first place to go. Talk to the radiologist. If you don't have a musculoskeletal radiologist, get the discs sent out to someone who has experience in looking at those, because osteosarc has often, periosteal elevation and matrix formation, bone formation in the soft tissue. There's a lot of features that they have. And then on MRI, there's different signal intensities that really show this looks like great for chondrosarc. So the radiologist said, no, this is definitely chondrosarcoma. Like the pelvis is a real good site for chondrosarcoma. Older people can get osteosarc, but I don't know if I guess I've seen some osteosarcs in the pelvis of older people actually. So, but I was like, but how do I explain this osteosarc component? So I must have missed this day in fellowship, but actually when chondrosarcoma dedifferentiates, it often produces either pleomorphic spindle cell, like looks like undifferentiated pleomorphic sarcoma, or it produces an osteosarcoma component. So this is actually D-diff chondrosarcoma with osteosarcomatous heterologous component, but you perfectly recognize that that's the main differential between those two. And I had to actually go back and look into this and realize, oh, this actually is not common. This is a relatively rare. D-diff chondrosarcoma is relatively uncommon, but actually this is well described that they do produce osteoid. So this is perfect though. If you just had a biopsy of this, I would have called this osteosarcoma. It's pleomorphic, ugly, high-grade cells making little wisps of osteoid, which is going on to join up and obviously pick up purpley blue calcium and turning into calcium hydroxyapatite. This is like the classic feature of osteosarcoma. And you are absolutely right too, especially if it's in a young patient. If you think you see a chondrosarcoma in a kid, you better make sure it's not, it's almost much more likely to be chondroblastic osteosarc, because kids just don't get chondrosarcomas. I've seen it in people in their 20s, but really rare, and I've never seen one in a child. I think I've never seen one under the age of 20, a chondrosarc. So in young people, that is absolutely really, if I see this area in a biopsy from a 10-year-old, I would say that's chondroblastic osteosarc, and I would probably, of course, I mean obviously I would check with the radiologist and make sure it made sense. But yes, so this is an area of dedifferentiated chondrosarcoma with heterologous osteosarcomatous components, and over here it looks more just like kind of UPS, like you don't really see osteoid formation, just sheets of ugly cells, some giant cells in there. So if you were really struggling though, the other thing you could do, particularly if you had a small biopsy or the radiology was not certain, does anyone know any molecular finding that you can use to help support a diagnosis of chondrosarcoma? Although it's not perfect, but it's supportive if it's positive.
Yeah, I think one of our fellows actually mentioned it in the chat. It would be IDH1 or IDH2.
Oh, I'm sorry. I don't even have the chat pulled up. I didn't even realize. I'm sorry. Yeah, IDH1 and IDH2 are mutated. One of them is mutated in the majority of cartilaginous tumors. That includes both benign things like enchondroma as well as chondrosarcoma. So it is not useful to tell you if you're dealing with benign versus malignant cartilage. But if you're telling, is it a cartilage tumor versus an osteosarcoma, it can be helpful if it's positive. Positive strongly supports chondrosarcoma. Negative does not disprove it at all because a subset of chondrosarcs are negative. So I always start with the radiology and all of those other features, but then in a difficult case, you definitely can send off for mutation analysis for IDH1, IDH2. And in hard cases, that can be helpful because there is actually not only a treatment and prognosis difference, but there's also a significant treatment difference. Chondrosarcomas, unfortunately, do not respond very well to chemo or any other thing. They're basically a surgical disease. D-diff chondrosarcoma has a very, very poor prognosis. The vast majority of these patients die within 5 years. And it's a really terrible diagnosis to have to make. Osteosarcoma is obviously very serious, but they have a specialized chemotherapy regimen that's often used, particularly in young people. And they tend to like to pre-treat them with chemo, at least my understanding from the oncologists I'd worked with. They often get pre-treatment and then get a resection. So there is a different approach that is taken. But so ideally, you like to be able to sort that out on a biopsy before the excision happens. And I can't remember what the biopsy showed on this one. I think it just showed the chondrosarc without the D-diff component because the D-diff area was actually relatively small in this case. And most of the tumor looked like regular grade 2 to grade 3 chondrosarcoma. So anyway, I'm sorry I put that one last because I knew I would go on and on because it's really just a very dramatic example. And it's something that, it's really rare to get a chance to see a specimen like this. And I really wish it would have been otherwise for the patient's sake. But okay, any questions about that or anything else? That's our last case.
So thank you very much for all this. This was a really good session. I have a question about what would be your advice for somebody who's interested in going into dermpath or soft tissue pathology? Like, what would you say that like somebody in their first or second year should start doing?
Great question. And I've actually been meaning, I made a little guide on my wiki website, like a page about like what to do, although this was long ago and pre-pandemic, so the world's very different now. So I've been meaning to go and update that and maybe make a video about it. But this is a good time to start that conversation. So I would say, soft tissue is there are not very many fellowships in it in bone and soft tissue, but it's not super competitive because not a lot of people are interested enough to spend a whole year doing it. If you like it, I would say definitely do a fellowship. Yeah, it's an extra year, but you'll have an amazing time getting to see really unbelievably rare, complex cases and learning from, the masters in the field. So I think it's great. And even if you end up going into a job where you don't do a ton of it, anytime anyone around you gets a bone or soft tissue thing, it will come to you. You may get to the point that you regret that decision, because there's certainly times where I'm like, these are all hard things people are bringing me. It's great when I can solve them. And for all of those slam dunk diagnoses, like the ones I showed you today, that once you know what they are, you can recognize, there's a whole bunch of stuff where I'm like, well, I really don't know what this is. And it's kind of maddening. It comes with the territory, I guess. But in any case, I would say spending time online. I mean, I've got a lot of content. I mentioned earlier, I've got a whole page of all my bone and soft tissue videos and slides. Spend time online looking into that stuff. See if you can find some interesting bone or soft tissue case that you've had in your institution that you could, look into writing up as a case report. And also maybe consider going and doing an elective at one of the centers that has a bone and soft tissue fellowship. I think that's always ideal if you're able to do that. So that you can, get a chance to work with those people. And especially when you apply for fellowship, that's helpful if they've had a chance to work with you. You can offer to do a project, when you're there, or even remotely contact them and ask if they have anything that you can work on with them. That can be a good way to get some experience, and also to show that you're a hard worker and that you're willing to hustle and you'll be a good fellow. Because, that's what the fellowship directors are looking for. People that are very smart and good diagnostically, but also people that are going to be able to help. I always say a fellow's job is to reduce entropy. And it's partly a joke, but I mean, seriously too, the fellows that are really amazing are fellows that when I'm like, oh, what's this next thing? Or where'd that case go? They're like, oh, I already took care of it. I ordered this. I showed it to Dr. So-and-so. Don't worry, this test is not back yet. They're on top of everything. And so it just reduces my anxiety and stress level, because I'm like, nothing's going to slip through the cracks if fellows are on it. So a really awesome fellow in any field, I think that's a goal. If you can be really organized and really like help out and be part of the team, that just makes life so much easier for your attendings and is so deeply appreciated by us. DermPath is a little bit, all of those things apply for DermPath, but also DermPath is a bit more competitive, right? Okay, a lot more competitive. A lot of people want to go into it. It is both Derm and Path can go into it. So I say that, if you think you want to go into DermPath or one of the other more competitive subspecialties, I think some people would lump HemPath into that. Although I know of plenty of Heme fellowship spots that sometimes go unfilled. So I don't fully understand why people say Heme is so competitive. Maybe it's just certain programs are. But DermPath definitely is competitive. So I think if you think you might be interested, try to get as much exposure to that early on. Get involved in writing up a case report or something, maybe a bigger project if you can. Try to do that early. If you change your mind later as a second year or whatever, then what have you lost? Yeah, you spent some extra time doing a derm research project that you don't really need, but it's not going to hurt you to have extra stuff on your CV, even if it's, if you go into Cytopath. No one's going to say, oh, we're not taking you to Cytopath because you got some DermPath papers. But if you do the opposite and don't get involved in DermPath stuff until your end of your second year, getting ready to apply for fellowship, in between second and third year, then you're going to be disadvantaged because most other applicants are going to have DermPath stuff on their CV. And even if it's not necessarily a bad thing to decide late. I mean, this is why I personally have trouble with the current way we select fellows and how early we interview people. But that's a much bigger problem that's beyond just me. So the point is because it's, it takes time to decide and figure out what you like, and then you're expected to apply for fellowship before you've even had a chance to rotate in some of these things. So in any case, the point is though, is if you wait, then it's a lot harder because other people that have started early will be advantaged over your application. So getting involved in research, getting to do away rotations, even virtual ones. More places are starting to offer those, and hopefully that will continue to grow over time. Getting a chance to work with people and show that you're smart, that you're hardworking, you're willing to stay late, you study extra stuff. I mean, be a go-getter, and that's what people want to see, right? They want to see that you're the person who's going to come in early, stay late, that you've got real hustle and that you really are passionate about DermPath. All of that said, I've seen people that are really good and do all the right things and sometimes don't get a spot. I do encourage you to plan that it's possible that you won't get a spot your first time. And if you really want to do DermPath, just keep at it and apply again if that's what it needs to be, even if it takes a couple times. Hopefully that won't be your situation, but I know that sometimes that happens. And that was what I told myself, is I was like, I want to do soft tissue and bone, and I want to do DermPath, and I'll take them in either order, and I'll keep applying until I get those. And that's what I want to do with my career. So I understand that's not always practical for everyone though. And obviously that's, you can't always do that, but trying to get involved in a project remotely, even if it's something educational. Sometimes people have asked me, can I do a project with you? And I'm like, I've got like 30 papers on my plate. I can't take on anything more. But I've let people help organize, whole slide image recut collections, or help with various educational social media related projects. There you can get involved in things like that. Get your dermpath mentors to make some videos and offer to help make the videos. I mean, I've seen times where people, because they had skills with social media or something else, that they were chosen over another applicant who was otherwise equal, that tipped the scale because the program director wanted help with that for their program, and the person coming in is like, yeah, I know how to use Twitter. And what I think the same's true if you know how to make teaching videos or do other tech related things like that. Spend time learning those extra skills. It won't hurt you, at least, to be able to say, oh yeah, I can help with that. I can solve that problem, even if it's not strictly dermpath related. But yeah, really, I mean, and always do well in your other rotations too. I do think that there are times where people come in and they like just want to do dermpath, and they kind of slack a little bit on other stuff and just think about dermpath. I might have been a little bit like that at times in residency, I have to admit. I mean, I think overall I worked pretty hard, but there, maybe were times I didn't devote as much to certain rotations as I should have. But that sometimes gets noticed, and that can reflect poorly on you if people think that you don't really care about anything, and if it's not related to dermpath. So really try to give your all on all your rotations, but certainly spend your extra spare time, learn as much dermpath as you can, read about it, tweet about it, post about it, get involved. Meeting people is really the key. And I used to say, go to meetings, go to the banquet at the ASDP, meet all of the program directors, meet everybody, get to know everyone. But now that's a lot more challenging because this year ASDP is going to be virtual again. And so obviously in the pandemic, it is much more difficult. But that's a place where social media can really help you. If you are not on Twitter, get on Twitter and use it every day and follow every dermpath there. I have a whole list on, if you go to my account under the little gear symbol, there's my lists, and one of them is dermpath, and there's 400 and some people on there. Go follow them. You don't follow, like, if you follow hundreds and hundreds of people every day, Twitter will like block you for a while. They'll think you're a bot. So take your time, don't mass follow. But in any case, yeah, follow, retweet, like their tweets, respond to their tweets, ask questions, and then you'll show up as someone who's engaged and interested. And it's something you can do with, 10 minutes of time every day, that your name's repeatedly showing up online. So it doesn't, none of this guarantees stuff, but it certainly, I would think, doesn't hurt. And I notice the people that really engage with my tweets all the time, even though I've got, 30,000 followers or something, almost, not quite 27,000. But I notice the people that are always retweeting, always asking questions, always in the middle of the conversation. Some of these people are junior people and I already know their name. So, you got to think, when a stack of applications come in, I'm going to notice the people, oh yeah, I know them. They're really cool. I've been interacting with them on Twitter for several years, and it's not going to hurt, right? Not every program director is on Twitter, and I'm not a program director anymore at Geisinger here. Dr. Fehringer is the program director. So I'm just speaking from my past experience and kind of my thought. Maybe not everyone has my viewpoints on these things, but those are kind of some general ideas, maybe more of an answer than you were looking for, but hopefully you find that helpful.
That was very helpful. Thank you for your experience and your expertise.
You're welcome. Any other questions? I don't want to keep you guys from your rotation, but I have time for you if you have questions. All right, guys. Well, if there are no takers, I'll let you go. And I hope you have a very nice day. Keep in touch online or otherwise, and hopefully we'll see each other in person one of these days.
Thank you.
Thank you so much.
You're welcome. Have a great day. Bye-bye.